All right, so I think we can get started. Hello, everyone. This is the October 2022 Heart Muscle Talk session, where almost each month we discuss research in the field of cardiomyopathies, and or we have keynote lectures. And I will ask the co-host Max Lorenzini, who's a consultant parts, to introduce the speakers.
Hello, welcome. And so this month we have the speakers from Trieste in Italy, and they'll be talking us through the role of genotype, phenotype in DCM and their role in stratifying prognosis. So without further ado, I think I'll leave the presentation to them, and we'll have a discussion following this.
Okay. So, thank you for inviting us to present our study on the importance of genotype on top of phenotype in managing dilated cardiomyopathies. My name is Alessia Paladin. I'll present with Dr. Matteo del Ferro. We are cardiologists registered, and I'm also a PhD student of Cardiovascular Department of Trieste Hospital, directed by Professor Sinagra. Let me spend some minutes to introduce this topic, starting from 4 different clinical cases. I'll give you a tip before starting. Only 2 of these cases during 5 years of follow-up after the first medical contact will have cardiac event. The first patient is Luca. He's a 37-year-old man with a family history of dilated cardiomyopathy and sudden cardiac death that we met during the family screening. This is his heart, a normal biventricular dimension, and mild left ventricular systolic dysfunction. The second patient is Davide. He is a 53-year-old man that we met during his first hospitalization for cardiogenic shock with the need of inotropic support. This is his heart with severe biventricular dilatation and systolic dysfunction with moderate mitral regurgitation. The first patient is Matteo, a 42-year-old male athlete that we met in our outpatient clinic during outpatient clinic reporting chest pain and palpitation. This is his heart with mild dilatation and mild left ventricular dysfunction and apical hypertrabeculation. The fourth patient is Giovanni, a 50-year-old man with an important family history of dilated cardiomyopathy that we met in our outpatient clinic reporting dyspnea. And this is his heart with left ventricular systolic dysfunction and dilatation, a right ventricle dysfunction, and a severe mitral regurgitation. From this data, we can hypothesize that the second patient, Davide, and the fourth patient, Giovanni, could be that one that will present the cardiac event for the severe dysfunction of the left ventricle, the right ventricular dysfunction, and the moderate to severe mitral regurgitation. But let's see if more clinical data could help us. At the magnetic resonance cardiac study, all the 4 patients show different degree of fibrosis. In particular, all patients present an intramyocardial fibrosis, in particular in the interventricular septum, but the first one had also a ring-like pattern of fibrosis. Moreover, all the 4 patients showed a ECG abnormal repolarization, but the first patient presented also a low voltages in the peripheral leads, and the last patient an atypical left branch block with frequent extrasystoles. So maybe this additional data doesn't really add any new information to our first hypothesis of bad prognosis about the second and the third patient. They give only a confirmation of that, but they do question the good prognosis of the 2 other patients. But let's see. Luca, during the follow-up, was implanted with an ICD and received an appropriate ICD shock on ventricular fibrillation. Davide as well was implanted with an ICD, but after that show a complete reverse remodeling in an optimized medical therapy with normal left ventricular size and functioning. Mario, after the training, show a persistent left systolic dysfunction that is more close to moderate dysfunction, but now completely asymptomatic. And Giovanni, during one of the multiple hospitalizations for acute heart failure, developed an electrical storm and an emergent LVAD was implanted. The patient was transplanted after a few months. So Luca and Giovanni, Luca is the first one and Giovanni the third one, had a cardiac event. But maybe it was not really easy to pick the two of them as an example of bad prognosis from the beginning. So we can try to see another point of view, the point of view of genotype. Luca is a carrier of a truncating variant of filamin. Ring-like pattern of fibrosis is typical of filamin truncating variants. Left ventricular ejection fraction is not associated with major arrhythmic events, suggesting that sudden cardiac death prevention for this patient should not only based on reduced ejection fraction. Moreover, in the outcome comparison of filamin with lamin and desmoplakin, established genes with high risk of arrhythmic and non-arrhythmic events, filamin carriers show a similar risk of non-arrhythmic outcome compared with desmoplakin, but still lower than lamin, and similar prognosis of lamin and desmoplakin in terms of major arrhythmic events. Davide is carrier of truncating variant of titin. Titin truncating variants are characterized by high rate of reverse remodeling in optimized medical therapy during follow-up. Moreover, if the presence of a left ventricular systolic dysfunction at baseline is predictive of cardiac events, the possible reverse remodeling seems to be protective. Mario is a carrier of pathogenic variants of myosin heavy 7. A recent report about this gene show a low rate of reverse remodeling and a low rate of major ventricular arrhythmias of myosin heavy 7 related dilated cardiomyopathy. Arrhythmic events and non-arrhythmic events seem to be associated exclusively with severe left ventricular systolic dysfunction, and myosin heavy 7 patient prognosis is similar to titin patient that is significantly better than lamin patient in terms of both arrhythmic and heart failure outcomes. Giovanni is carrier of a pathogenic variant of lamin. Lamin is the first and the most notable established model of arrhythmogenic cardiomyopathies with a significant high risk of arrhythmic and non-arrhythmic events. Moreover, a predictive score for 5 years of ventricular tachyarrhythmias is available integrated international guideline to support the decision for ICD implantation for the primary prevention of sudden cardiac death in lamin carriers. Indeed, in the presence of similar phenotypes with different degree of dilatation and dysfunction of the left ventricle, a significant genetic and prognosis heterogeneity could be present. And of course, overlapping phenotypes between dilated cardiomyopathy and arrhythmogenic cardiomyopathy makes clinical and phenotypic classification extremely difficult. But it's also true that genotype classification could be challenging, since mutation of the same gene could be causative of different phenotype. However, it's possible that this complexity is present because we want to distinguish between many different phenotypes. But the question is, it could be reasonable in the field of genetic cardiomyopathies to consider different phenotype in the same group of non-hypertrophic cardiomyopathies and let genotype define the patient prognosis. Has phenotype ever been compared to genotype in terms of define the patient prognosis in genetic cardiomyopathies? The answer is no. So the purpose of our study, this is actually impressed on Jack, was to assess the prognostic prediction of initial clinical phenotype-based classification versus applying a genotype-based classification in a large cohort of patients with non-hypertrophic cardiomyopathies, carrier of pathogenic or likely pathogenic variants of cardiomyopathic genes. The study population included a primary cohort composed of patients with non-hypertrophic cardiomyopathies, carrier of pathogenic or likely pathogenic variants, and a second expanded cohort of patients with non-hypertrophic cardiomyopathies testing negative for pathogenic or likely pathogenic variants. All these patients were included in the familial cardiomyopathies registry of Trieste and Denver, Colorado, between 2016 and 2019. Non-hypertrophic cardiomyopathies group included dilated cardiomyopathy, defined with the presence of left ventricular ejection fraction less than 50% after a careful exclusion of secondary causative etiologies. Arrhythmogenic right ventricular cardiomyopathy, defined according to 2010 task force criteria. Left dominant arrhythmogenic cardiomyopathy, defined as dilated cardiomyopathy presentation with more on equal to one of these criteria. Sudden cardiac death or major ventricular arrhythmias, defined as resuscitated cardiac arrest, ventricular tachycardia, or appropriate ICD intervention, unexplained syncope, more than equal to 1000 PVC per 24 hours, and more than equal to 50 couplets for 24 hours at the ECG monitoring, and the biventricular arrhythmogenic form, defined as arrhythmogenic right ventricular cardiomyopathy plus left ventricular ejection fraction less than 50%. All the patients had a baseline clinical assessment, including ECG, as well as an echocardiographic evaluation and altered ECG monitoring. Moreover, all the patients have been genetically tested using target NGS panels, including at least 20 validated genes. Genes variants were classified as pathogenic or likely pathogenic according to American College of Medical Genetics and Genomic criteria. And to obtain a statistical meaningful comparison, genes represented by fewer than 20 genes represented by fewer than 10 patients were excluded from the analysis. Finally, only sarcomeric genes were grouped in a gene cluster, including troponin T2, myosin heavy 7, troponin C1, and actinin 1. Our primary endpoint was a combined event of all cause of mortality and heart transplant, and the second endpoints were differentiated in arrhythmic secondary outcome, including sudden cardiac death and major ventricular arrhythmias, and heart failure secondary outcome, including heart failure death, heart transplant, and valve implantation.
Okay, thank you, Alessia. So I'll show you briefly the results of this study. So the initial cohort was, as already mentioned, 824 patients, mostly DCM, 80%. So we are a referral center for DCM. Then, consistently with previous report, only 1/3 of our patients were carriers of pathogenic variant in a disease-related gene, so were affected by Mendelian cardiomyopathy, let's say Mendelian non-hypertrophic cardiomyopathy, so 315. And as already Alessia said, we excluded 34 patients because they were carrier of pathogenic variant in genes with few numbers, few numbers. So phospholambda and BAG3, BM20 was excluded, and we ended up with our study population 281 patients, all affected by Mendelian cardiomyopathy, DCM, arrhythmogenic right ventricular cardiomyopathy, or LVC, biventricular cardiomyopathy. So mostly from Italy, all Caucasian, or almost all Caucasian, 99%, and 80% dilated phenotype. And this was the genes that we identify, titin, plakophilin 2, desmoplakin, filamin C, lamin, and the sarcomeric gene cluster. So in this histogram, we can represent the phenotypic heterogeneity behind each genotype. So in line with the fact that we are mostly dilated cardiomyopathy patient, the most represented gene is titin, and it's almost completely associated to a dilated phenotype, while no sarcomeric gene, such as desmoplakin, plakophilin, filamin C, is already known and that's expected, has an heterogenic phenotype. And plakophilin 2 was mostly associated to RVC, while sarcomeric variant, myosin heavy 7, myosin binding protein C3, or troponin T2 was associated mostly to DCM, pure DCM phenotype at enrollment. And this is our cohort from a genotypic point of view and from a phenotypic point of view. So don't be scared by this table. This is just to show you that phenotype-based classification works efficiently, categorize patients also in this cohort of Mendelian cardiomyopathy, non-hypertrophic, and we can see that the DCM cohort has a higher prevalence of severe left ventricular dysfunction, of left bundle branch block, or mitral regurgitation as expected, while RVC or LVC patients show more frequently a history of sudden cardiac death as expected, and a history of competitive sport. We can see that the largest genetic heterogeneity was seen for DCM cohort, 6 gene, while followed by LVC biventricular cardiomyopathy, associated to 5 genotypes, and then RVC, which was associated in our cohort to 4 underlying genotype. So phenotype-based classification works and categorize patients also if you are talking about only Mendelian cardiomyopathy. So these are other small differences. So another important fact is that the phenotypes tends to evolve over time in this cohort. So the genotype is stable while the phenotype tends to switch. Mostly about 20% of our cohort switched from DCM to ACM, arrhythmogenic cardiomyopathy, or dilated or RVC during follow-up. And so this is so from a clinical point of view, this could be important since you need to reassess the phenotype during the follow-up. So, and this is the most important thing that we see about the evolving phenotype. So, and this is the table of variables classified according to the genotype at enrollment. So we have more categories of patients. So desmoplakin, plakophilin, filamin C, lamin, sarcomeric, and titin. But the surprising, I mean, the expected thing is that also this kind of categorization works in effectively distinguished patients. So as expected, the titin and sarcomeric variant show the more severely depressed ejection fraction at enrollment. The left ventricular ejection fraction were quite normal for plakophilin 2 carriers, and show a moderate depression, let's say, in desmoplakin and filamin C and the carriers. Lamin show a severely depressed ejection fraction. Also, right ventricular dysfunction was enriched in the cohort of patients with desmoplakin and plakophilin 2 as expected. Another important thing is that the categorization by gene allows to enrich some kind of clinical variables in specific genotypes, and this is the case of atrial fibrillation and atrioventricular blocks for lamin carriers. So both at this point we can say that both classification works in efficiently distinguished patients, although the variables are slightly different. And then we move to phenotype characterization. We move to prognostic characterization of these two kind of classification of patients, phenotype-based and genotype-based. So also to accomplish a reviewer question and for statistical reason, we grouped arrhythmogenic cardiomyopathy and LVC, biventricular cardiomyopathy, in the umbrella term of arrhythmogenic cardiomyopathy, and we can do safely it since they are not so different from the survival analysis as shown in these two Kaplan-Meier and cumulative incidence function for sudden cardiac death and major ventricular arrhythmia. So since now on, the phenotypic classification will have two variables, dilated phenotype and arrhythmogenic cardiomyopathy. And these are the survival analysis according to phenotype at enrollment. So in yellow, ACM, in blue, DCM phenotype at enrollment. This kind of classification seems effective in stratified patients, but mostly or only for the arrhythmic outcome, while it is not so efficient in stratified patients for the primary outcome in our cohort. While for the heart failure related outcome, they are not statistically different. So, okay, this kind of classification, phenotype oriented, works in Mendelian cardiomyopathy, but it works only from the arrhythmic outcome in our cohort. Then we move to change classification, and we observe what are the survival curves of patients classified according to the underlying genotype. So on the left, you can see the survival analysis. For the primary outcome, the green line identify lamin carriers, which show the worst prognosis in terms of death in respect to the other genes. And in respect to the arrhythmic outcome, you may assess that these four non-sarcomeric genes, which are desmoplakin, filamin C, lamin, and plakophilin 2, show a remarkably similar rate and higher rate of arrhythmic events. In the table, you can assess the incident rate of events in desmoplakin, plakophilin, filamin C, and lamin, which are remarkably similar, between 30 and 23%. While on the other side, the carrier of titin and sarcomeric genes have a lower rate of arrhythmic events, quite similar. So to obtain a clinically meaningful and a statistically meaningful comparison, we decided in this moment to group the different genes. So we group non-sarcomeric genes since they show similar arrhythmic event. So desmoplakin, plakophilin, filamin, and lamin were grouped into a single category, arrhythmic genes. And then we group sarcomeric and titin carriers in another category. And we compare them against this with the same endpoints. And these are the survival analysis. So in our cohort, we were quite satisfied by this curve because this kind of categorization, according to genotype at enrollment, was able to stratify patient prognosis also in respect to the primary outcome and for the arrhythmic outcome as expected, while there was no statistically significant difference for the heart failure related events. So this is just another way to assess this comparison. So on the left, phenotype-based survival analysis. On the right, genotype-based survival analysis. So you may appreciate the difference in stratify the patient's risk for the primary and secondary outcome. And in our hands, this kind of classification seems more efficient in respect to the phenotype-based classification. So maybe we can go back to this point later, but probably this increase in accuracy is due to the fact that this classification is able to categorize DCM phenotype, since behind DCM phenotype there is the largest genetic heterogeneity. And in our cohort, for carriers of desmoplakin or carrier in lamin or in filamin C, the rate of major ventricular arrhythmia was similar regardless of phenotype at onset. So this is a sort of visual abstract of our study. So we start from the onset phenotypes, non-hypertrophic, that underwent genetic testing with NGS. And so a patient were then categorized according to the underlying genes. So plakophilin, desmoplakin, filamin, and lamin, and sarcomeric genes and titin. Inside each gene category, there is a evolving phenotype during the follow-up, with a switch mostly from dilated phenotype at onset to arrhythmogenic phenotype. But if you decided to group these patients, then we can carefully assess the prognostic risk of, and not relying on the phenotype, but on the genotype. In green, we have the proportion, the largest proportion of patients will turn out to be pathogenic or likely pathogenic variant negative after genetic testing. So then we assess this prognostic prediction in a multivariable model, and in respect to the study population, Mendelian cardiomyopathy, 291 patients, the genotypes seems more accurate and was associated with a higher odds ratio to the secondary outcome, arrhythmic outcome, and also to the primary outcome. The phenotype in this model was mildly protective for the primary outcome. Probably because in this analysis, DCM phenotype is enriched of genotypes such as titin or sarcomeric, so with a less arrhythmic, with a less represented arrhythmic burden, we think. And then the reviewer asked us to enlarge this analysis, and we thank the reviewer because we think that this fact gives more strength to our result. So we included in this multivariable model also expanded cohort of, let's say, genetic negative or gene elusive patient that was negative for pathogenic or likely pathogenic variant after the next generation sequencing test. And the cohort was quite similar for phenotype representation at onset. So we include this cohort in the multivariable model, and we compare both arrhythmic genes, genotypes, and genetic negative, let's say, phenotype against, in a three-variable model, against the carrier of titin and sarcomeric variants. And in this model, genotypes turn out to be, again, strongly associated with the arrhythmic outcome. And also, genotype, being carrier of a variant with arrhythmic genes was strongly associated with a higher hazard ratio to the outcome, primary outcome, as shown in survival analysis. So we have to acknowledge many limitations of this study. This is a retrospective study with two referral centers mostly for dilated cardiomyopathy, which represented 80% of our population. Due to statistically insufficient number of individuals, we must exclude carrier of variant in rare genes, so reducing the spectrum of clinical and prognostic characterization of a larger genetic DCM and DCM population. And then we do not consider, according to validated criteria, we do not consider MRI data in this study. So in conclusion, we can say that a genotype-based classification provides a different but efficient prognostic classification, both for clinical variables and for the prognostic prediction of genetic cardiomyopathy. This could lead to a consideration about the fact that actually the available statements by principal cardiological society usually provide phenotypically oriented guidelines, while after this study, we can at least support the idea that if we are talking about Mendelian cardiomyopathy, maybe an approach in which patients are first classified according to the underlying genotype. So, for example, titin cardiomyopathy, filamin C cardiomyopathy, or desmoplakin cardiomyopathy may further be useful and improve their clinical management and prognosis stratification. So it seems, according to our data, that the presence of a specific mutated gene is superior to a phenotype-based classification in the prognostic assessment in a heterogeneous genetic non-hypertrophic cardiomyopathy population, and regardless of phenotype, desmoplakin, filamin C, lamin, and plakophilin PK and KP2 predict a higher rate of sudden cardiac death and ventricular arrhythmia in respect to being carrier of titin or sarcomeric variants. Lamin show the worst prognosis in terms of non-arrhythmic events. Thank you.
Oh, that was really nice. Thank you very much. Really interesting. Then congratulations for publishing the paper in JAC. So hopefully we'll be able to read it soon as well. So for everyone who's attending, if you would like to ask a question, so as someone has already done, you can use the Q&A button, and then everybody can see your question, or you can send in the chat, and then we will be able to see it, or you can raise your hand, and we can let you talk and ask your question or make your comment. I would like really to start first, if that's all right. So would you then recommend that any patient with a non-hypertrophic cardiomyopathy has a genetic test? Which kind of genes would you suggest that these patients need to do? And also, which I suspect you might say yes. So how would you integrate in clinical practice the fact, let's say, that someone has a desmoplakin variant? How would that change what kind of decisions you make, in practice?
Okay. Oh, okay. So thank you for this question that I already forgot.
So would you do genetic testing in everyone?
Yeah.
Is the first part.
In our center, we are since 6 years ago, we are starting with a strong genotyping of all cardiomyopathy patients. So it is strongly debated, and one of the reviewers asked us something similar. So, and actually some consensus documents recommends genetic testing after careful clinical classification after the diagnosis. Geneticists often have the same idea, so the genetic testing only after the familial screening, after everything at the end. On the contrary, we would like to support the idea that genotype from a prognostic point of view is useful from the beginning. Just to exclude lamin, just to exclude desmoplakin or filamin C is already something. Then it is a data that allows you to interpret also the clinical assessment of the patients in a different way. So you can differently consider the late gadolinium enhancement or differently consider the arrhythmia according to the underlying genotype. So in our opinion, and we wrote it, we would like to insert the genotyping during the classification process and not at the end of the classification process. And our genes, if I remember correctly, we have a panel of 34 validated genes now. And one of the strength point is probably that we mixed everything together. So we do not have a dedicated panel for dilated or a dedicated for AVC. We have a structural cardiomyopathy panel with some channelopathy inside. And and from a couple of years, we are working with the clinical exome. And so we can do virtual panel after and drive it according to this clinical suspect.
And it sounds that, like, for centers that are not kind of very, it's not very easy for them to do a lot of genes. Maybe at least the high risk ones that you presented are kind of mandatory for DCM patients, at least, right?
Yeah.
And so how would you integrate in clinical practice? Then was this my second kind of part of the question? Like, how, let's say you have someone, let's say, as you presented at the beginning, same ejection fraction, one is desmoplakin, one is titin. Does that change your threshold for implanting an ICD, or how do you approach that?
I mean, the clinical assessment must be present and complementary. But the truth is that actually, if we see a titin, we are more likely to wait for the remodeling. We are more likely to wait for the ICD implantation. This is this is a current clinical practice. And on the contrary, if you see a lamin, or if you encounter, maybe we think for devices before. Basically, therapy is quite similar, but device therapy is beginning to change.
So I want to jump in as a devil's advocate here, and I mean, the disclosure is I'm obviously a big fan of genetics in guiding prognosis, treatment, and what to expect. But if we start saying that everyone with a non-hypertrophic cardiomyopathy needs genetics, and we have a definition that's as broad as a mild LV dysfunction that's otherwise unexplained, that's a huge cohort of patients. And even in a selected cohort in a referral center such as yours, the pickup rate of mutations was quite low. So we'd expect it to be even lower in an unselected cohort. So the question is, how do we justify such extensive genetic testing? Is it effective when the yield is so low?
I agree with you, but I think we should use a sort of historic approach to this behavior, since at the beginning we were focused only on patients with a higher probability of being carrier of pathogenic variants in multi-generational families, or really important phenotype with myopathy associated with so high probability. And so the insight that we have from the genetic is only in the cohort selected with this bias. We are moving to extend the genetic in a larger population with mildly clinical impact or mildly clinical phenotype. So, and probably after this phase, we can go back and say, okay, it's useless to do it. It does not help us, but at least we can say it. We don't know exactly the prevalence or the odds ratio of being carrier of this variant in general population. We have some insights from UK biobanks, but they are not so careful from a clinical point of view when you assess this kind of patients. So I think that maybe this extensive genotyping is quite necessary in this phase, a sort of to demonstrate something, if it worth or not. But since we never done it before, we don't know. This is my opinion. So, because for sure we are still missing something, not only for non-Mendelian cardiomyopathy, but also for Mendelian cardiomyopathy. From an historical point of view, I say the classical example is the unexplained or resuscitated cardiac arrest with normal heart. For years, it has been tested only for channelopathy genes. We don't know structural genes, if they are affected or less behind this kind of presentation. So I think it is worth investigating all genes behind all phenotypes and then reassess once we have all the data. Actually, I think we don't have still all the data.
Okay, so more in a research setting than massive clinical rollout.
But excluding lamin from a prognostical point of view, from a clinical point of view, somehow helps. This is another way to see this story.
Okay, and my second question is, I'm stealing directly from Alex, but it's a recurrent one in these talks. So should we be moving from talking about DCM or biventricular cardiomyopathy or ARVC to talking about DSP cardiomyopathy and filament cardiomyopathy and lamin cardiomyopathy? Should we turn it all upside down?
Yeah, absolutely, yes. This is my opinion. A reviewer, I think a reviewer asked us to write something like this, and we did it. So I think that for Mendelian cardiomyopathy, it could be useful to move to a definition of cardiomyopathy that relies on the gene. So titin cardiomyopathy or desmoplakin cardiomyopathy. I mean, this has an impact only in 1/3 of our patient. No, and the other is difficult to. It is still under investigation from a genetic point of view, polygenic score or whatever.
But that means that the larger group, so the titans and some of the more frequent genes, will have enough data to start risk stratifying them effectively. we'll still have trouble with the smaller genes, as you had trouble with the small numbers and the low event rates. We'll struggle even collectively to have enough data to guide us if embracing this kind of classification. Because if we then say, so how do we manage RBN20 cardiomyopathy? And we need good data to guide us there, and it can be difficult to gather. Yeah,
it's true, but also in a large group of like Titan, we have to understand which are the clinical data that can suggest that that patient is going to have reverse remodeling or not. We know that Titan mutation is correlated with high rate of reverse remodeling, but with the group that doesn't go to the reverse remodeling, what is the point of what are the clinical data that suggest that are not going well, that patient? So also the big group of patients, of the group of big number of genetic variants should be investigated more. So maybe focus on Titan patient and try to understand if there are second hits that could explain or justify a left ventricular dysfunction or something that is connected to the not present of reverse remodeling. There is a lot of things that maybe if we focus on different group and be specific for genes, it could be a specific medicine in the future, and also think about medicine specific for genetic variants and not for patient with dilated cardiomyopathy, you know.
Yeah, it's the way for precision medicine. This could be the right approach to drive research in this context, starting from the genes and then analyzing the different phenotype inside the genes, because it is another way to see the same thing, but could be the right one to progress in precision medicine.
There is a question from the audience. So actually there are two of them. So the first one says, if you had any chance to check any VUSs or variants of unknown significance in the gene negative group, and potentially whether that has any kind of impact.
So we thought to take the VUS
to ignore them.
Yeah. Because we think that in them there are some VUS that are no VUS, or VUS that are likely pathogenic, but now we don't know they are like pathogenic or benign, and we are not sure that they are benign. But yeah, then we put all together and we consider with the negative genetic testing, and so we put in a negative for likely pathogenic or pathogenic variants altogether. Yeah.
It's also in our previous experience, you are not accepted to publish something with the VUIS carriers, since basically they do not exist as we know. They are or benign or likely pathogenic, but we are not able to classify them correctly. So usually they are considered as being genetic negative or non-carrier of SO. So we included them in the genetic negative cohort, let's say, in respect, regardless being carrier of a VIUS.
Okay. And there is another question about myocarditis-like events and whether they have a prognostic role in desmoplakin-related DCM.
Hi, Michele, if it's you, I thank you for the question. And in this study, we did not assess this kind of endpoint in the desmoplakin cohort, but for sure it is worth investigating in the subset of desmoplakin patient, this kind of onset arrhythmia. This question is useful for the previous question of Massimiliano about the indication for genetic testing. 5 years ago, nobody tends to genotype myocarditis. But actually, there is a sort of new wave of investigating for structural variant behind the myocarditis-like onset. So it is a new field for research.
And there was just another question now saying, what do you do for genetic negative DCM, HCM cases? Is it worth doing trio whole exome sequencing, carry on for functional experiments?
We would like to. I think that in the next few years, hopefully, some new research will start to spread some light in this difficult setting. For sure, it is a heterogeneous population from a genetic point of view. False negative, copy number variation. It is a really heterogenic population. Sometimes there are recessive diseases that we usually miss. And in some cases, but anecdotally, we did some trio research with exons, but we do not have any kind of reliable variants identified with trio actually in this genetic negative. The truth is that also there are clear familial cases with a clear genetic based, but all kind of genetic test turn out to be negative in these families. So there is still a large amount to work on.
I guess the gene negative or gene elusive cohort is always a mixed bag, and who knows what different entities exist in there.
Yeah.
So I think the other thing that I wanted to not really ask, but just get your opinion on. So I mean, you've shown how the different let's say genes or gene groups have different numbers in terms of incidence of outcome. But as you know, and your team has taken part in our recent kind of paper on ARVC, where we've shown that actually, depending on the genotype, you will have also different risk factors. So it's not just about, let's say, the amount of outcome you get, but also the way to predict that outcome might be different from gene to gene. What do you think about that? Do you think that's going to happen in DCM as well?
It is a good hint. We did not assess, but that's probably one of the things that will start to emerge when we will investigate gene-specific cardiomyopathy. Maybe in this setting, we can try to assess the risk factor. There is a study recently published in which they identify risk factor for being carrier of a pathogenic variant, but I think it is not the same question of your.
Yeah, so I mean, like, do you think we'll end up with a Titan calculator, sarcomeric calculator?
We could be worse. Yeah.
So yeah, that would be so eventually the message is that we need to be doing a lot more genetic testing. The problem is who is going to be interpreting all that genetic testing, and who is going to be seeing all these all these patients, I guess. How do you think about that? Do you think that this is a problem, or do you think that the field is going to catch up and genetic testing will become a lot more available?
Hopefully, yes, it will become more easily available. I mean, we should make a difference probably between referral center and non-referral center in the availability of this technology. But hopefully, with this kind of works, such the hours and others, the evidence on the benefit of the genotyping stratifying patient prognosis are quite strong. So hopefully it will be more easily available, at least for a while in the future. Then maybe we can get a step back and focus it. But actually, I would like to extend it.
Okay. Yeah.
So I'll step aside, and I wanted to ask you about, I thought it was interesting, the part where you mentioned the changing phenotypes, the progression in phenotypes. So there's some RV involvement in some DCM patients, and I also expect some LV involvement in some of the ARVCs. and I wanted to ask you to comment on that, and if you saw any, if that was an indicator in any way towards prognosis and events, and what significance we can read there.
Mm-hmm. So yeah, it was a very interesting part where I agree with you, and we asked ourselves if it would be correct to do a comparison between genotype-based classification with phenotype-based classification at the end of the follow-up, as well as we did with the phenotype at the baseline. But it's a completely different approach. I mean, we don't know how the patient is going to be after 4 years of follow-up. So is that the point, one of the point to compare genotype and phenotype? Genotype is that one, is not going to change, is there, is going to be present in the patient and also in the family, care in the relatives. But the phenotype is changing, is evolving, so we should be careful to take a picture of the patient only at the baseline and don't think that patient, it could be completely different after 2 years. And maybe the presence of phenotype, of a specific genotype, is predictive of that. So we should be more careful. For example, if there is a filamin or a lamin, then I don't know, psychometric variant about some patient. So maybe genetic could help also to decide which kind of follow-up we want to that patient. For 6 months, if we are in a unstable phase, or 1 year of 2 years, it could be completely different for a patient with filamin or a lamin or I don't know, lack of filin in the case of arrhythmogenic right ventricular cardiomyopathy.
Maybe from a research point of view, it could be useful also to go back into pathogenetic processes behind each gene. So maybe if you look to titin, it could be just an evolution of left ventricular dysfunction. Then when it is more severe, it starts becoming arrhythmic because of the dysfunction. So this could be the case of titin, the evolving phenotype of titin. In the other cases, so it helps in identifying, in our opinion, different pathogenetic processes, which probably needs different precision medicine approaches. Always for a research point of view, this could be another way to look at the problem. But in respect to the clinical evolution, probably it's just an advanced form of the disease that became biventricular or start to doing arrhythmia because of the more severe depressed ejection fraction.
Okay, so as we are approaching the end, I would like to ask you now a provocative question. So someone who wants to be a bad reviewer might ask, okay, so what you're showing maybe is not the genotype that's important, but it's actually the scar. So you have all these genes that cause a lot of subepicardial scarring. So maybe it's the distribution of the scar or the amount of the scar and not really the gene. How would you approach that question?
The main limitation is the absence of probably one of the most next study will focus on this.
Yeah, but except for Padua criteria and the diagnosis of arrhythmogenic or left dominant arrhythmogenic right ventricular cardiomyopathy, magnetic resonance doesn't be useful for the diagnosis of dilated cardiomyopathy or arrhythmogenic cardiomyopathy. Yeah. So this was the point of the study. We are starting from a diagnosis, the phenotypic diagnosis with clinical point, ECG, echocardiography, that what guideline asked to us to do. And then we try to compare phenotype and genotype without consider MRI. We know that is a missing point, but it was not this the purpose of the study.
But do you think, sorry, but do you think that maybe these genes are more, let's say, arrhythmogenic because they cause all this scar, or do you think just the scar is something not necessarily relevant for the arrhythmic risk?
It is still debated, I think. I mean, for plakophilin, for example, someone says that it is not necessary to have the scar. For lamin, also, and for Titan also. So we don't know. We can turn this question to the guideline makers of the next. Because it was provocative also for this kind, because clinical classification is really complex, really complex. All the criteria, every patient can switch from one to the other because of a couple of ventricular ectopic beats, or so. The improvement should involve also the phenotypically oriented guideline.
Yeah, of course, and also that was only an example, but the patient that I showed you before, the Lamin patient, he had only a small amount of fibrosis at the level of the interventricular septum, as well as the Titan patient, you know. So, okay, maybe, of course, it would not help to have Lamin carriers to have a fibrosis. We don't know if that one that moved the arrhythmic part, but the same amount of fibrosis detected by LGE, because we didn't talk about the T1 maps or something like that. But of course, it was not the point of that patient. Maybe it was more that was carrier of Lamin carrier, a Lamin variant.
Yeah.
Yeah, I mean, I agree with you. That's what I think as well. And I mean, depending on the gene, like for example, PKP2 also causes a bit of channelopathy, let's say, and probably there's a lot more beyond the scar that works in favor of the arrhythmia substrate that we don't know. So it's, you know, it's that makes a lot of sense.
Agree.
Okay, Max, do you have anything else, or shall we wrap it up?
No, I think it's time to wrap it up.
Okay,
So,
well,
thank you for that very interesting talk, and we'll see you next month.
Yeah. Thank you.
Thank you very much.
Thank you very much.
take care,
Bye-bye.
everyone. Thanks for coming.
Bye.
Bye.
Thank you.
Bye.